Thank you so much, Julia, and it's always a huge pleasure to be part of the event each year for the Psoriasis Association. So, as Julia's highlighted, I'm based at Manchester, the University of Manchester, and I'm going to talk a little bit about the work that we established to create the Global Psoriasis Atlas. But more importantly, as Julia's highlighted, we undertook a really important piece of work on behalf of the Psoriasis Association. I'm going to show how that work's really started to influence the programme that we deliver in the Global Psoriasis Atlas and some of the early impact that we've been achieving with that. So a little bit of history first about the genesis of the Global Psoriasis Atlas. Many of you remember back in 2014, the World Health Assembly recognised psoriasis as a serious non-communicable disease. And that was quickly followed by the Global Report on Psoriasis in 2016. One of the key kind of highlights of that report that stood out to myself and Professor Chris Griffiths was a real call to action around improving our knowledge on the epidemiology of psoriasis in terms of its incidence and prevalence at the global level, and starting to standardise some of the methods that were being used. And that was at the time the call to action. So in 2017, on the 1st of April, we established the Global Psoriasis Atlas, and I'm really pleased to be here today, which is our 10th year, to share with you some of the achievements that we've been able to create over those 10 years. So the GPA, or the Global Psoriasis Atlas, is very much a long-term project that really seeks to drive improvements in our understanding of the global epidemiology of psoriasis, how that affects individuals and societies at large. Our mission has always been to be the common benchmark for the burden of psoriasis in all countries and regions across the world. So a very ambitious mission, because when we go into the data, there's many gaps in our knowledge, and that's what we're trying to kind of close. So our vision has become the leading epidemiological resource globally of psoriasis. And I'm really pleased after 10 years, I think we've achieved that. You know, when we went to the World Congress, lots of our data was being used, the GPA brand seemed to be well established. So we're really pleased for what started off as a really small group in Manchester has really expanded globally, and we're really pleased with the network and the achievements we've been able to create. So we're into our 10th year, and just to give you a feel for the programme of the work that we do within the Global Psoriasis Atlas, a big focus is on improving our understanding of the epidemiology of psoriasis. And in the last phase of the last 3 years, we've been really building up our knowledge base as well around generalised pustular psoriasis, an area where even less is known. We lead a programme of work to improve early diagnosis of psoriasis, and we've got some resources I'll show you that we've developed and tested to try and improve that. We conduct programmes of work examining and exploring the comorbid disease burden of psoriasis, so looking at cardiovascular, psychiatric, other long-term conditions that are associated very often with psoriasis. And in particular, we've done some exciting work looking around kind of access to care and how that might affect the economics of impact of psoriasis. But as I mentioned, our kind of main thrust is really respond to the call from the WHO to improve our global understanding of the epidemiology of psoriasis. And what we've undertaken over several phases now is create the most comprehensive data set on the global epidemiology of psoriasis. So this was our last publication that was published in the British Medical Journal back in 2020, where we pulled together systematically all the available data about how common psoriasis occurs in the general population in countries across the world. And a number of figures really kind of jumped out when we undertook this exercise. There's around 60 million people in the world globally that we estimated had psoriasis on the basis of a physician diagnosis. What was really interesting as we looked into this data set, only about 1 in 5 countries had reliable data. So this was the challenge that the WHO had thrown out, and this is what we're trying to kind of improve. But when we looked at that data across different countries, the prevalence of this disease really did vary quite markedly. So through our work, we've undertaken new studies in many new countries, and I'm just showing you examples of some of the recent work that we've published. So we worked with colleagues over in Poland using the national Polish health fund database, similar to records captured within our NHS in the UK, to characterise the incidence, the prevalence, mortality associated with psoriasis for the first time in Poland. We've looked at comorbidities, as I'd mentioned, and this was a recent publication this year in the British Journal of Dermatology, where we looked at the most comprehensive analysis of risks of establishing up to 26 cancers in people with psoriasis. And we used, through our networks, large population data sets from the UK, from Denmark, from Taiwan, and from Israel as well. And with a common protocol, we were able to show consistency across these different countries as well. And as I mentioned more recently, in this latest phase, we've really started to improve our knowledge about the epidemiology of generalized pustular psoriasis. And this was one of our first studies that we undertook with a regional data set in Malaysia, where GPP presents much more commonly, I think, than what we see in the UK. But what was really interesting with this data set, we were really able to characterise how often it appeared in different ethnic groups. And as we look at the published literature, this is an area where we know very little. So that has led us on to the work we've done for the Psoriasis Association as well. And it was a fortunate coincidence because we just completed the work from Malaysia, looking at ethnic variations in psoriasis. And Helen reached out and said, do we know anything about ethnic variations in the UK? And the answer was pretty quick, no, we don't. We had no data available at all. So an opportunity arose for us to start to explore this and understand these patterns much more within the UK data set. So we're very fortunate at the university. We have access to large anonymised population-based health record data set called the Clinical Practice Research Data Link. So essentially this is a number of GPs who use routinely collected healthcare records from general practices that completely anonymise to support public health research. And this was how we kind of worked to analyse this data. We linked those GP records to hospital episode statistics so we could see if people are admitted to hospital and what diagnoses were kind of captured in those records. We linked them to the ONS mortality records, so for any death certificates are registered with the Office of National Statistics, so we could see the validated cause of death for anyone within those records. And we also had measures of index of multiple deprivation. So that's a measure of socioeconomic status at a small population level, usually about representing an area of about 1,500 people. And the most interesting thing is the Clinical Practice Research Data Link had created an ethnicity record very recently. So this was the opportunity to, for the first time, to really understand how the presentation of psoriasis vary between ethnic groups. And what they'd done is looked at recordings of ethnicity in GP records, in hospital records, and really cleaned that data up. So we had, you know, kind of a more comprehensive understanding of who was presenting and their ethnic backgrounds within that data set. And we had a number of key questions that we wanted to answer. We wanted to understand how the epidemiology of psoriasis varied between different ethnic groups within the UK, as we described. We were conducting this work just after the COVID pandemic, so we were interested in what the impact of the pandemic had been on diagnoses of psoriasis within the health service. So that was another piece that we were interested to explore further. And the last time we'd looked at this was back in 2013 in the UK. So we were really interested to see whether the prevalence of psoriasis at that time seemed to be increasing, whether that was continuing to increasing. And if it was that due to more new diagnoses being made? Or was it because life expectancy for people was improving? And either of those factors can really influence the number of people with psoriasis in a population. So that was what we were keen to explore. So just to give you a little bit of insight into the Clinical Practice Research Data Link, this captures anonymised data from GP records. So there's literally billions of consultation records, all completely anonymised, available, and it provides really rich insights in terms of exposure to drug therapies, diagnoses and symptoms that are made by practitioners looking after people. As part of those consultations, we can see referrals to health services. We can see laboratory test results, vaccination history, and some limited kind of demographic data too. The data is fully coded, patient identifiers are removed at source, so we can't identify anyone within this, and the closest indicator is some broad kind of regional, representation that someone is located in the northwest of England or in London, for instance. So yeah, we really can't identify anyone, but the real strength is when we're able to kind of link this data set to some other records, and that provides much richer insights. So what did we find? So our psoriasis population from these records, we looked over a large study window from 1998 up to just after the pandemic in 2022. So we had a psoriasis population of over 1.1 million people with a recognised diagnosis in the health records of psoriasis. And this gives you a little bit of detail about just the demographics of the population we're studying. There were slightly higher women within that sample than men. And for the first time, you can start to see the breakdown, I think, in terms of ethnic groups within that. Clearly, the white population dominate that within the UK, but we were able to kind of identify substantial cohorts of people from Asian backgrounds, black and mixed populations as well. And within the ethnicity record, we were able to kind of break some of those ethnic groups down further, I think, to really understand some of these, kind of the distribution of psoriasis within those populations. So for the first time, we had some insight in terms of how psoriasis varied within the UK by ethnic groups, which was a real step forward, I think, because so few publications have ever reported this in any country, I think, coming through. So we looked at the prevalence of in terms of over time and how that varied by gender. And as you can see, the prevalence is still creeping up. And as we reported in 2022, the overall prevalence was 2.8%, so just below 3% within that population. And again, as we've highlighted from the earlier slides, slightly higher in women than men within that group. We broke the ethnicity down, looked at the prevalence rate by ethnicity groups, and again you can see that the prevalence is much higher in the white population, but we can also see the prevalence in the Asian population and black population, and not surprisingly the mixed population sits in between those estimates that's coming through. Here we report on the incidence. So the incidence relates to the number of new cases of psoriasis diagnosed within a period of time. And as you can see, there's no kind of strong pattern that actually the incidence is increasing over time. You can see quite a sharp drop-off around about 2020, and that was answering our second question about what happened during the COVID pandemic. And like many long-term conditions, people weren't presenting to health services and diagnoses did drop, but you can see how that is bouncing up, I think, after the pandemic subsequently, I think, coming through. And again, as we look, we took the opportunity, as we did this work for the psoriasis, it wasn't part of our original brief to look at GPP, so it was almost buy one, get one free exercise, I think. But it was a really worthwhile exercise for us to undertake, because we built a better understanding of generalised psoriasis into our programme, and there was so little data out there, in particular from the UK. So given that we were looking at the records, we wanted to characterise this as well. So we looked at the prevalence of general pustular psoriasis. It's much rarer than psoriasis, I think, coming through. But we can see slight increase in the prevalence over time, and here again slightly higher in women than men. And we looked again between ethnic groups. Because it's much more rarer, we had to collapse some of these ethnic groups down because the numbers were quite small in some of the groups. So we're only able to report this, unfortunately, in quite broad categories, I think, coming through. But again, it's the first time we've got some insight in terms of how this varies between ethnic group within the UK. For both studies as well, we're able to look at, provide new insights into mortality and life expectancy as well here. And I don't think it's a surprise to anyone in this room that we know from previous studies that GPP has a higher mortality rate than psoriasis and from the general population. And we're able to show that within our data too. What we're also able to show as well is some of the main causes of the deaths within this cohort. And I think that's really important for population health measures. If we start to understand this data better, we can think about pathways and treatment and management programs to help target some of these issues. So yeah, for both papers, we've reported on major causes of death and also life expectancy within that for the first time in the UK as well. So both of those studies are under review with the British Journal of Dermatology. So I'm hoping in a few months' time we'll be working very closely with the Psoriasis Association to kind of disseminate these findings much more widely. The work from GPP is already having impacts as well. So it was really timely that we were undertaking this work for the Psoriasis Association. So at the time, many of you may remember that NICE was conducting their appraisal of the first treatment for GPP. And to be fair, I think it was quite a challenging kind of period for the Psoriasis Association responding to some of the comments that were coming through from NICE. And we were starting at that stage to generate some of our outputs. And I'm really pleased to say that through the work we did, we were able to provide some data on resource use in health services by people with GPP that fed into this NICE appraisal process and meant ultimately that the drug was approved for use within the UK. So already some early signals of impact of the importance of some of the work feeding through into that process. So as I mentioned, epidemiology is our main programme, and what we recently did is update our global systematic review. It's a major exercise every time we do this, but we identified in our latest update up to 2025, 92 new studies. Most of these relate to understanding the prevalence of psoriasis. We found 4 studies that just focused on incidence and 12 that looked at both prevalence and incidence. So we've updated our data set and we relaunched that on World Psoriasis Day in October this year, I think coming through. But And if you're interested in finding out, data about the prevalence of psoriasis, look at the website. We've got all the data there, and it gives you opportunity if you want to compare between different countries, how that profile explores. But what's most important to us as well is there's lots of data there, but we work very closely with people with lived experience as well. And we've got lots of people who've generously shared their stories about psoriasis. And I think this is so important and powerful to us because behind the numbers, there's people. And actually their stories really kind of show the importance of some of this work and what it means, I think, in trying to understand that. Alongside the website, we have a huge number of national coordinators. So this is our kind of global map, and there's 145 countries that we work really closely with. And this very much is the engine room for the Global Psoriasis Atlas. It supports our programs of work because I've described how we've conducted work in the UK, many other countries using routinely collected health records, but in many parts of the world, we just don't have systems and structures like that, and huge gaps in our understanding about how common psoriasis affects some of these populations. So, one example of this that we found is just a single study from sub-Saharan Africa, from Tanzania, actually. Very old study published back in the 1980s, showing a very, very low incidence of psoriasis of 0.1%. So part of our programme is also to improve our understanding of the epidemiology of psoriasis in countries where we have no data. And that's led us to undertake field studies in some of these countries. So our first one was back in Tanzania in 2019. And this really, kind of illustrates the challenge, I think, for many people living with psoriasis globally. It's a population in Tanzania of 57 million people with only 31 dermatologists. So you can imagine that most people living with psoriasis don't have access, to dermatologists at all. And if they do, they have to travel huge distances. So the diagnosis and treatment of psoriasis is often provided by non-specialist healthcare workers. Treatments that are available in some circumstances, if you're referred into this, often topical therapy such as coal tar, salicylic acid preparations, or some steroid creams, I think, coming through. Methotrexate, when we visited Moshi in northern Tanzania, was the only systemic treatment, and people used that intermittently when they could afford to purchase it, I think, coming through. So we went out, and one of the real pleasures of this, we worked very closely with dermatologists from across sub-Saharan Africa. We spent an afternoon where we co-designed what an epidemiological study would look like in that context. It was absolutely fascinating, I think, and we learned so much about how we'd operate in the field on that. So we put some of that into action, and we went into northern Tanzania and actually did a skin disease survey of the Maasai population, and it was absolutely fascinating experience. So if you're interested, that work was published in the British Journal of Dermatology by Sidra Khan, so you'll be able to reach the link and read a little bit more about that. But that workshop that we did about co-developing, a kind of epidemiological field study in these settings really underpinned what we did back in 2023, where we, for the first time now, conducted the cross-section epidemiological study. And this time it was in the Eastern Cape of South Africa. So it was an international collaboration, a team of 16 dermatologists that we led from the UK, from Israel, from South Africa. We had some industry volunteers that were supporting operation activities on the ground, and 21 local communities. It was a really rewarding experience. We went into 2 villages, and this is the poorest region, I think, in South Africa, and actually did house-to-house screening of individuals, for skin disease within that population, for the first time providing data to those local health services. So you can see a little bit of our action and what we found. Skin disease was extremely common in this population. 63% of the people we screened actually had some form of skin disease. Psoriasis, we did see some cases, but again, like the data we've seen from Tanzania, it's a very, very low prevalence, I think, in the population. And we were able to kind of publish for the first time data from, kind of areas of the world that we'd never had any insight into. But we've conducted numerous field studies now, and the recurring themes that always come back to us, particularly in low and middle income countries, is that the diagnosis of psoriasis is often delayed by many, many years. It's often provided care through healthcare workers, not necessarily clinicians, etc. And actually, it's commonly misdiagnosed very often as a fungal infection, such as tinea corporis, I think, coming through. But also, what's really important is it really shines a light about how psoriasis really presents very differently on different skin colours and tones, and that's really underpinned some of our efforts to develop training tools to better recognise psoriasis. So we developed some clinical criteria around psoriasis and how we can establish both an operational definition, an essential and supportive criteria to accurately diagnose psoriasis. And our work then moved to build this into a diagnostic training tool. And instead of using photographs, what we did, we worked with a graphic artist who developed pictures. Imagine if you look at a bird watching book about how they represent the characteristics of different birds. It's really important to kind of describe some of the key features to aid the correct and accurate diagnosis of psoriasis. So we worked with an artist who did some wonderful images, I think, that really supported this. As you can see, just describing some of the more salient features to watch out for to make sure that people can get the appropriate diagnosis. And at the time when we developed the tool, we were in the middle of the pandemic, so we couldn't go travelling around the world and such like. So what we did is we conducted a field study in the UK, and we recruited groups of general practitioners, groups of nurses, and groups of pharmacists in the UK. And we provided access to our diagnostic training tool, so it provides information in the images, and it provides a baseline test so we get an understanding of how accurate they can diagnose psoriasis, are run against a mix of pictures of psoriasis and other conditions mixed up that might often get confused as psoriasis. And they undertake then, the reading of the exercise and the images, and then they retake the test later. And what was really interesting, across these 3 groups, we showed that the diagnostic ability to detect psoriasis correctly was improved after taking this diagnostic test, which took about 15 minutes in total to complete. So really important. So this is something that we're really kind of pushing, I think, within the Global Psoriasis Atlas, recognising that many people across the world don't see clinicians, and they certainly don't see dermatologists. So actually getting a correct diagnosis and putting on the appropriate treatment pathway at an early stage is really important. So we've got projects at the moment running in the Netherlands with GPs who are trying this tool now, and then we're going to hopefully get this on our website and roll it out much more widely. The other piece that I mentioned was around access to treatment, and this is one area that we've really pushed forward through as well. So one of the big exercises that we conducted this year was our Global Access to Care survey, a cross-sectional survey of 25 questions. And we invited 3 dermatologists from each country across our global network, so we can, for the first time, provide some benchmarking data about access to treatment. So we've recently closed the survey. We had 453 dermatologists from across the world representing 183 different countries and territories. So a really important and valuable data source for us to kind of benchmark issues about access to care, access to treatments across the world. And the importance of this is really driven by some of the steps we've taken. So Professor Griffiths, who's the director of the Global Psoriasis Atlas, led the application to submit the 2 biosimilar drugs, adalimumab and ustekinumab, to the World Health Organization Essential Medicines list. And we were delighted, kind of at the end of last year when these things were approved and for the first time have been adopted by the Essential Medicines list by the WHO. So our survey works in hand with this now. We've just completed it. It'll give us a baseline assessment globally about access to treatments, and we'll be able to go back and revisit this in time to see what change and improvements may be occurring. So lots of exciting programs underway. If you'd like to find out more about the work we're undertaking, please reach out to us. I'm going to be around all day. Chris is arriving if he's not here already. We've got other members from the Global Psoriasis Atlas team here as well today, so please do reach out. If you're interested in the work we do, we've got our newsletter. You can subscribe through the QR code or the social media channels, etc. But I want to thank all our sponsors that has allowed us to undertake this work, and in particular for the work that we've done for the Psoriasis Association, which has been so important to us as well. So thank you very much.